Hello, everyone, and welcome into Senior Living Live. My name is Melissa. I hope you, all of you joining us today are having a fantastic day. We are shifting gears in our webinar from the many discussions we've had on mental health to now our physical health today. And we would all like, of course, to lead a healthy lifestyle that keeps us active and moving. And one way that we can do that is to take care of our bones and our joints. Dr. Donald Hohman is an expert of this topic. He's an orthopedic surgeon at the Texas Joint Institute. His patients, they receive the latest and greatest when it comes to care and technology, and he joins us today to discuss that and a whole lot more. Dr. Hohman, welcome, and thank you for taking the time to join us today.
Thank you for that kind introduction. So my name is Don Hohman. I'm a orthopedic surgeon. I'm board certified in orthopedic surgery, and I'm also fellowship trained in adult reconstruction. And so what that means is that's what I do. I take care of arthritis. I take care of bone and joint issues day in, day out. I specialize in joint replacements, whether that be hip replacements or knee replacements. I also take care of people who have problems with joint replacements. So we also specialize in redo joint replacements. So the vast majority of the people that I see and take care of, they are patients that have some form of an arthritic condition. And that's what I'm going to share a little bit about today, how to keep things going. What are the what are the options? The vast majority of people that I see and treat are without surgery. But we'll talk a little bit about what the end of the line may look like from a treatment standpoint, meaning a joint replacement when people have exhausted all of these other options. So if you want to get started, we can go through these slides. I think probably what would be best for everybody is if any of these questions come up, we'll just save them. I can address all of them at the end. So I'll run through these kind of quickly, and then we can address any of these specific topics and any specific issues that might be up when we're finished. Just as a quick brief outline, much like we've previously discussed, we'll talk about arthritis, what you might be experiencing if you are experiencing one of these arthritic conditions. We'll talk a little bit about wellness and healthy tips. We'll talk a little bit about what the treatment options might be, and that'll lead us into what the final solutions for some of these conditions might be in the form of operations and specific operations, depending on individual circumstances. These conditions are very, very common. And so what I want to make very clear is that what we're going to focus on with this discussion is going to be osteoarthritis. And the reason this is important is because there's other types of arthritis. And so, for example, you may know somebody who has what I commonly refer to as a deforming arthritis, where you'll see the changes in people's hands where the fingers will become crooked or something like that. And those generally fall under the rheumatologic conditions like a rheumatoid arthritis or a psoriatic arthritis or something along those lines. Those are a little bit of a different animal, and those are autoimmune disorders where people's immune systems will destroy their joints. Now, those arthritic conditions may wind up with the same final common pathway, meaning that they may ultimately wind up with a joint replacement the same way an osteoarthritis patient may, but those are for different reasons. And so for the purpose of this discussion, if we're going to talk about arthritis and use the word arthritis, we mean run-of-the-mill osteoarthritis. And this is very common. And essentially what this is it's as much a mechanical problem as it is a loss of the cushion on the end of the bone. So what I tell people, if you think about cartilage is just like when you eat chicken. If you look at the end of the chicken bone, when you take the chicken bones apart, there's a nice, shiny, smooth surface on the end of that bone. Well, all of your joints in your body have a nice, shiny, smooth surface on them. And those two surfaces, those are what touch together and make up the joints. And those surfaces are actually amazing when you look at the basic science of them, because they basically are friction-free, they're very soft, they glide, and they're smooth when they're healthy and they're working well. And when they start to deteriorate, they start to break down and they start to uncover the bone underneath, and then that becomes a rough surface, and that becomes a very irritated surface. And that's essentially what osteoarthritis is. So just think of it as run-of-the-mill wear and tear. I tell my patients it's kind of like when you've lost tread on your tire. It's a rough surface. It's irritating, creates debris, just like the bits of your tire may eventually break off. That's essentially what goes on in the osteoarthritic joint as well. And so think about that around your knee or your hip. And so these things are very common. And so when we look at x-rays, we'll see various degrees of arthritis, and people will present at various stages. And so when people come in with these early conditions, we sort of tailor the treatment to these early treatment, maybe even preventative treatments. People will have mid-range arthritic conditions, and so sometimes that necessitates a little bit more of an aggressive treatment approach, maybe an injection or maybe some kind of bracing. And oftentimes people will present with some of these really terrible arthritic conditions. And oftentimes these are women who will show up with these really advanced arthritic conditions. Women are just wired differently than men. And so they tend to tolerate these things for really, really long periods of time before they finally seek out treatment, because they're busy taking care of everybody else. They don't stop to think about themselves and take care of themselves until they have some condition that leads to them not even be able to walk. And then they show up and you look at them and you wonder, where's this person been for 10 years? And oftentimes that's a nice lady who's been taking care of other people for a long time and not taking care of herself. So we see people with all different degrees on the spectrum, and we modify the treatments accordingly based on where they might be in this kind of cascade of a progressive condition. I really like this slide because this slide really sums it up. I get asked this question every single day: how did this happen? Why did this happen? And so I tell people over and over again that arthritis is really kind of an interesting condition, in that we don't really know a whole lot about it. We do know a lot about it, but the more we learn, the more we realize that we don't learn. And so we're starting to learn more about the genetic components that may predispose people to this. Oftentimes you'll meet people who need their hip replaced, and they'll say, yeah, well, my mother needed her hips replaced and my grandmother needed her hips replaced. And so when you start to look more into the genetics of these issues, you'll see that some people are just predisposed to these conditions. Oftentimes we take care of a lot of people who are involved in accidents. If you have a break into your knee joint, or you have a dislocation of your hip, or your hip breaks or something like that, trauma can lead to disruption of that nice smooth surface, and that can lead to early deterioration of the joint earlier than it might deteriorate. Rarely do we see people with infection, but it's not unheard of. And so the problem with infection is that infection creates a very acidic environment. And so an acidic environment will lead to very rapid deterioration of that cushion inside the joint, and that'll lead to early arthritic changes inside the joint. That'll become painful and stiff and a problem. Inflammatory conditions basically fall into the same category. So you can have repeat gout attacks, for example, that can lead to that same disruption of the metabolism inside your joints, and that can destroy your joint as well. And metabolic issues are also more common than you might think. For example, the more we're learning about diabetes, you hear lots about heart disease and diabetes. Well, those same sugar molecules that are circulating in high concentrations in a poorly controlled diabetic bloodstream, those can also attach to your cartilage cells, and those can also create earlier deterioration of your joints. And so we're only starting to learn about these implications and what this really means. But we do know that controlling these metabolic conditions can definitely help prolong the life of the joints. And aging. So I tell everybody, if we're all lucky enough to live long enough, everybody's going to wear the tread down on the tires. And so you'll see people that are it's not uncommon. I see people living into their 100+ years, and of course they're going to have a few miles on those hips or those knees, and so oftentimes they'll show some changes of some arthritic conditions as well on their x-rays. And then I really like the cartoon on the side, because this really shows you all of the things that people with arthritic knees, for example, will show up with. So that arthritic knee might look a little bit thicker or bigger than the other one, and that's because the tissue that surrounds the knee is responding to the constant irritation inside there, and it starts to become a little bit thicker. And so you'll notice that an arthritic knee might have a little bit of a thicker capsule than a non-arthritic knee. You'll start to see some of these cysts that are developing on the x-ray, and they're usually pretty obvious when they get to be pretty extensive on the x-rays, and that's an early sign. Oftentimes it can even be a later sign of an ongoing arthritic condition inside that knee, as fluid gets pushed inside the bone and it shows up as a cyst inside the knee bone on the x-rays. And those terms of sclerosis of the subchondral bone, those are also indicators of chronic pressure changes that you'll see on the x-rays. And that fibrillated cartilage term, what that means is that as that smooth surface starts to get flaky and starts to break away. It starts to almost look like hay blowing in the wind as it starts to break off, and those little bits will break off and float around and create further irritation as the cascade continues inside the knee joint. And so what will happen then is, as the irritation continues, the lining of the joint will get continuously irritated, and that'll lead to lining of the joint becoming thicker, and that's the synovial hypertrophy. And then as bone starts to feel pressure from the other bone, it starts to make more bone. That's all the bone knows how to do. And so as it feels pressure from the bone touching the bone, it starts to try to decrease the pressure in that local area by increasing the surface area. And so you'll see people with these bumps on the side of the knee, and because that's the natural response of the bone. As it feels pressure, it starts to try to create more bone to decrease that pressure. And so this is what arthritis looks like on x-rays. So you'll see that top left picture, there's a lot of space between those bones. That's where the healthy cushion lives inside that knee. You'll see there on the bottom one where the bone is touching the bone. That's where the cushion has worn away. And then on the hip x-ray, which is that top right picture, you'll see that there's a nice round ball. Normally the ball of the hip looks like a nice round ping pong ball. Well, you see that bottom right picture, that hip looks almost like a mushroom that you stepped on, because you're starting to see some of those extra bones grow around the bottom, and you're seeing that bone touch the top of that hip socket. And hip arthritis can be very painful, just like knee arthritis, and you can actually develop these same arthritic conditions in any of the joints in your body, whether it be your elbow or your shoulder. More commonly, these are showing up as hip and knee issues because you don't walk around on your shoulder. So people oftentimes will tolerate an arthritic shoulder or an arthritic elbow for a very, very long period of time, and they can even have a very dramatic appearing x-ray, and it's not really bothering them because you don't walk around on your shoulder. But if you have a really bad hip or a really bad knee, that can be really debilitating and really limit your quality of life and really limit the things that you can do. So what are we here to focus on? What are the things that you can do for your joint health, whether it be your hip or your knee or your back or your shoulder or anything? And so some of these things probably seem intuitive, but I think it's nice to go over some of these just as reminders, because these are things that really make a difference. You know, there's a lot of hocus pocus out there, and there's a lot of people that will tell you lots of different things and try to take money from you for different things. But these are the things that science has really shown us that can make a difference and can really help you. And so I see a lot of people with arthritic conditions, and they are oftentimes on the heavier side. And I've even had people that have been very heavy, and I've had a discussion with them about weight loss. And they've even been to the point where they are considering an operation, and they even have a small amount of weight loss. And that has such a huge impact on their level of symptoms that they decide that they no longer need an operation, that they're continuing to do better and better with their weight loss, and they're not hurting as bad. And the reason that is because if you can lose 1 pound up top, the way the mechanics work around the hip and the knee, 1 pound difference up top can translate into about 5 or 6 pounds less on your hip or your knee with each step. And that can make a big difference. So if you do the math on that, you know, you meet people that sometimes have an issue with a little bit extra weight. You just multiply whatever that number may be that you can do from a weight loss number, and that can be a huge difference on your hip or your knee with each step. And that can make a big difference in people. And I've even had people that have been ready for an operation by the time I meet them, after we discuss weight loss strategies and how big an impact that can have for them. By the time they show up for their surgery, they've decided that they no longer need it. And that's also very rewarding. And, you know, it's little things like that can make a big, big difference. And so, you know, just maintaining an active lifestyle. So the best thing for joints, even if they are arthritic, even if they are deteriorating, is to keep them moving. And so, you know, it's actually the pumping action of the joint is actually what feeds the remaining cartilage inside there. So I don't discourage people from doing any kind of activities as long as they're not hurting themselves or, you know, creating further issues that might further limit their activity. But maintaining your activity is definitely not making your arthritis worse. Oftentimes people with arthritic conditions can actually improve their symptoms by, you know, oftentimes they describe it as getting warmed up. So once people are up and moving around, sometimes their symptoms from these conditions can settle down. And so it's something that we encourage, and we definitely have these discussions. From a bone health standpoint, as well as from your joints, low impact exercises cannot be understated. This is really just the tried and true. So, you know, we take care of a lot of people with osteoporotic conditions. And so what's the number one thing that you can do there? Just aside from making sure that your metabolism is correct from a vitamin D standpoint and a calcium supplementation standpoint, but the best thing that you can do is low impact activities. And so load bearing on the bones is one of the best things for density. And so if you're osteopenic or osteoporotic, and you might be discussing how to best manage these things with your primary care doctor, thinking about these things, whether it be lightweight training or just any kind of even walking provides you with adequate stimulus to help your bone health in general. And these things are also very safe and effective for your arthritis management, or maintenance of your activity and your overall health from your skeletal and joint health standpoint. Flexibility is definitely something that can help relieve your symptoms as well. So in particular, when it comes to hip and knee arthritis, what'll start to happen more so in the knee even than the hip is that as you become more arthritic and you start to create more of that extra bone, your motion will become less and less. And so knees tend to lose motion. They start to contract. They stop straightening out. And you'll notice that your hips, for example, you can't lift up your leg to put your shoes on because as this process progresses, the space around the joint starts to decrease and the capsule will start to contract. And so it's a bad combination. And so trying to keep things limber and keep your joints moving definitely can help hold off that process if this is happening. And it's generally just feels good and is helpful to try to incorporate some yoga or some kind of low impact or simple stretching into your day-to-day routine for all of your joints. There's essentially no downside. Can't hurt yourself, and keeping your motion, especially your range motion around your hips or your knees, can definitely help you avoid any symptoms that you might be experiencing if you are experiencing some deterioration of the joints. Posture is another one. I see lots of people with hip and spine issues. It's very common for people to have an arthritic hip, for example, with an arthritic back, or a low back issue that they think it might be their hip. And so it's every single day I see patients that think they might have a bad hip. They maybe have a little bit of early wear and tear, but they're actually experiencing symptoms that's coming from their low back. And so posture is the reminder that I have for myself, just to put in here to discuss general overall core strengthening and the importance of that as sort of the first line when we see patients that have these overlapping symptoms. You always want to make sure that somebody's core strength is up to speed and that they are doing everything that they can to take the pressure off of their disc spaces, because that can create all kinds of other problems. And so posture is just another one of those things just to think about. It's a constant reminder. But before we talk to anybody about any kind of operations, especially any kind of back operations or any of those sorts of things, we exhaust all of these core strengthening measures to make sure that not only posture is corrected, core strength is addressed, healthy low back translates to a better functioning hip. And so before anybody winds up with any kind of surgery, we definitely make sure that we have all of those bases covered. And these things, there's a lot of discussion and a lot of various schools of thought when it comes to dieting, and having some interest in some of these things, and my own personal bias, I guess. But I'm a believer in everything in moderation and a well-balanced, healthy diet. I don't subscribe to any of the extremes of all or nothing kind of approach. And so after having reviewed extensive research relating to these topics, I'm a believer in everything in moderation, calories in versus calories out, and healthy, well-balanced diet. And so you might hear or feel strongly about other topics, and some of these things. I oftentimes have these discussions with patients as well. But this is my 2 cents when it comes to diet: is avoid the extremes, stick with the simple, healthy, well-balanced fruits and vegetables, and that'll definitely provide you with the nutrients and the support that you'll need from a joint health standpoint. That's for sure. Hydration can't be understated. These are things that the reason this comes to mind is because when we're looking at that nice shiny, smooth surface on the end of the bone, the basic science of that is actually astonishing in that the majority of that surface is actually water. And so the way that those molecules that make up the cartilage surface and the way that they glide and the things that are key components for them to work and do what they do is they actually need the appropriate concentration of water. And so staying hydrated is also important for your joint health, in particular in the arthritic conditions. When it comes to supplements, when I was making the comment earlier that there's a lot of people that will try to sell you different things and take advantage of you and sell you a bill of goods. There's all sorts of arthritic treatments out there from a supplement standpoint because there's lots of people out there with these conditions. And so the take-home message there really is: are some of these things going to hurt you if you're taking them? The chances are probably not. But are they going to do anything for you? Chances are probably not. There's not a lot of really good evidence that any of these supplements do anything from a joint health standpoint, and they're readily available. They are not regulated, and so in a lot of ways you don't even know what you're getting in some of these supplements. So I generally tend to caution people, but I have met people who swear by turmeric, for example. And I've also met people who've, I've replaced their knees and they've been taking turmeric every day of their life because of their dietary preferences. And they'll tell you that it has done nothing for their joint health. So I don't discourage people from any of the choices that they've made. I just tend to caution people, just, buyer beware, and just be aware that the basic science support for a lot of these supplements that they're trying to sell you for joint health is generally not really there. So just be careful and make sure that if you are taking something, for example, people on blood thinning medications, your general medical doctors need to know if you are taking some supplements, because there's always a potential for some interactions with some of your other medicines that can potentially be detrimental. So I do caution people, just make sure that you're being transparent with your providers about what you are taking for whatever reasons you may be taking them, just so that they know how to calculate those interactions that might be potential issues with some of the other medicines that you're taking for other medical conditions. When it comes to arthritis of the knees, sometimes you can have a deformity that can be braceable. So, for example, at times people will wear only one compartment of the knee, and so if you'll see somebody with a curved knee to the inside, sometimes you can put them into a brace that can help offload a compartment, and sometimes that can be very effective. And even sometimes people will have just a general arthritic condition in the knee, and a little bit of compression on the knee can be very helpful and relieve some of their symptoms. Simple arthritis braces can be very helpful. And so this is something that we usually will exhaust when we are trying the non-surgical management of these conditions, and make these available to people as something to try before we start trying things that are a little bit more aggressive from an intervention standpoint. So a lot of times people will ask me, I hear a lot about various types of injections. And so there are various types of injections. One of the first injections that we would try for arthritis, whether this be your hip or your knee or your shoulder or your elbow or whatever joint we may be trying to take care of and relieve your symptoms, that would just be something as simple as a corticosteroid injection. And they're generally, really very safe. There's almost no downside. Diabetic patients sometimes will have a little bit of an increase in their blood sugar that we encourage people to monitor closely afterwards. But corticosteroids are a fast pain relief. We usually would use some numbing medicine when we were to put those into the joints as well. And, if people are getting ready to go on vacation, for example, and they need to be as good as they can be before a trip to Europe or Hawaii or something like that, we'll inject knees with corticosteroids so that they're feeling as good as they can while they're trying to do some hiking. That's a common application for these. We use them, pretty liberally, or, in all different joints. The challenge with steroids is that they work well for a period of time, and then the next time that period of time is shorter, and then the next application, that period of time is shorter. Now, how long that will be is different for everyone. I have patients that come in every 6 months for a steroid injection. I have patients that come in once a year for a steroid injection. I have patients that come in after the steroid injection and say it didn't do a whole lot for me. So it's really kind of a wide spectrum, and the only way you'd really know which one of those responders you would be is if you try it. So if we've tried a steroid injection and that has stopped working or it's not working, the next level of things that we consider are the hyaluronic acid injections. Those are the gel injections. These are, commonly used. Lots of people generally, in my experience, have some experience with this, or they know someone who's trying them. And this is really the same kind of thing. Some people seem to do really, really well with these for a long period of time. Some people don't feel like they get much out of them. There's different types of them made by different manufacturers. And so there's a three-shot series, there's a one-shot series, there's several different iterations. And so I'm not opposed to trying those for people. Some people seem to respond to some people don't respond to any. And so it's just like the steroid injections, which one of those people you'll be. We don't know until we try, but we exhaust all of these options with people and we make them all available. As long as we can get your insurance to approve them, oftentimes that's a hurdle as well. The insurance companies are not really crazy about these because there's not a lot of overwhelming research that says they do a whole lot. And that's another discussion that I usually have with people when they're considering these gel injections. But the reason we make it available is that there's really not a lot of other things that we can do. Some of the other things that are, in my opinion, a little bit more, cutting edge or experimental, you'll hear a lot about stem cells or amniotic injections, those kind of things, and even platelet injections. For me, these all kind of fall under the alternative injection therapies. And so while I don't discourage people when it comes to these, the things that you need to be aware of with this are as follows. So in particular, when it comes to platelet injections are potentially really, really interesting, really very effective, but you just need to be aware of some of the potential issues. And we're still getting some of these things worked out through basic science research. So the platelets, they potentially have anti-inflammatory effects, but the other thing that we're hoping is that if we can catch people in these early stages, these hopefully have stimulatory effects to where they may be able to help preserve or repair some of the damage that may have already happened within these joints. And there's been a lot of studies that have shown that these platelet injections, and when I'm referring to PRP, that's another common term that you'll hear for this, these injections can outperform the gel injections when you look at them and you study them head to head. And so while that is very encouraging and that's great, insurance companies haven't really caught on to that, and they won't pay for your PRP injections, and oftentimes they won't even pay for your gel injections. So it's tricky, and so there's some hurdles that you need to jump over and jump through with some of these things, but these are the things that are available. The other thing that you need to be aware of when it comes to these PRP injections or any of these stem cells or amniotic injections or anything like that is that there's really no standardized process for this right now when it comes to these applications for knee arthritis or hip arthritis or any of these kind of conditions. And so, again, these are just things that are just being borne out through research. And so there's huge interest in this, and there's a lot of this that's going on. But right now, nobody knows what's the best dose or what's the best method or what's the best way to process the injection so that you can get the maximal benefit. The only way that we're going to know that is through basic science research, and that just takes time. And so that stuff is ongoing. There's a wide range of techniques and processing methodologies, and what that leads to then is a wide range of what you will get in that spun down injection that you might be considering injecting, say, into your knee or your hip or your elbow or wherever you might be trying to make yourself feel better. So just be aware of that. Just know that we know enough now to know that we don't know. But there is some research that supports application of these, and these kind of things are probably going to have a bigger role moving forward as soon as we have some real evidence and real research that shows us how to use them the safest way and the most effective way. And so then when people have tried all of these things, we've exhausted everything. We've tried all the injections, we've tried the braces, we've feel like we can't live this way. Then when it comes to arthritic pain, and that's where we start talking about what the surgical options might be. And so we specialize in joint replacements of the hip and the knee, and so that's what we'll focus on. So people with badly arthritic hips, we talk to them about total hip replacement. People with arthritic knees, sometimes we can replace only a portion of the knee, which is really, really nice. It's a smaller operation and it's an easier recovery. But some people wear out the whole knee, or some people have a really severe deformity and they need their full knee to be replaced. And so that's who we talk to about total knee replacement. So, total hip replacement is a great operation, and it's done for the right reasons, and that's pain relief. People with hip arthritis, it can be a debilitating condition, can be really limiting. I mean, it's just hard. Every activity of life can be challenging with a badly arthritic hip. And so, some of these people, I tell them, and they don't believe me at the time, but I meet people who have such a badly arthritic hip. I tell them you're going to wake up feeling better after surgery, and they laugh every time I tell them. But I, see them after surgery, and they say, "My God, I can't believe it. You're absolutely right." And so, what a hip replacement is where we take that badly worn, crushed ping pong ball out of that deformed socket, and we reshape those. And titanium shell goes into the socket portion of the pelvis, and a titanium stem will hold a new ball that'll rest on a new bearing surface. And when these are put in there in the appropriate orientation, that gives you a pain-free hip to get back to your normal life with. Be very, very effective, and it's a very rewarding operation when done for the right reasons with the appropriately motivated patient. Can make a world of difference for people. Partial knee replacements are great operations also. There's essentially three components inside your knee that can be worn down. You can wear out the inside or the medial compartment. You can wear out the outside or the lateral compartment, or some people will wear only the patellofemoral or the kneecap portion of the joint. And so you can do a partial knee replacement for any portion of these knees that might be worn. And so it's sort of akin to, if you go to the dentist and you have one bad tooth, you don't go and have all of your teeth worked on. You just have that one bad tooth taken care of. And sometimes you'll see people that have only a medial portion of the knee that's worn down. And so we'll get to the point where we need to address just the medial portion of the knee. And why do people like partial knees more than total knees? The reason is that they keep both of those ligaments inside the knee. So when you do a full knee replacement, the ACL usually is not functional to begin with, but the ACL comes out. And those knee ligaments are important because they talk to your brain. They help communicate to your brain where your knee is in space. And especially in younger people, they tend to like to have those ligaments function if they can. And so when we do a partial knee replacement, we leave those ligaments intact. And so these knees function better. They perform a little bit better for, in particular, younger people. And people are generally happier with this. It's less surgery, it's an easier recovery, and it's less blood loss, all of those things that go along with a shorter, smaller operation. And partial knee replacement patients can be really very happy when you find people with the right kind of problem for this kind of solution. A total knee replacement is not, don't get me wrong, it's not a bad operation, and it works very well, again, for the right reasons, pain relief. And it's not as though we chop out the whole knee and plug in a new knee. So what I like about this picture is you just have to appreciate what we're looking at there. The metal cap replaces, quote unquote replaces, it's actually just a resurfacing of the end of the bone. And so that diseased cushion that's no longer on there, that portion is trimmed away. 7 or 8 millimeters of the portion is what comes off in a shape to where we just resurface the end of the bone, and we do that on the end of the end of the femur and on the top of the tibia, and then the kneecap joint can be addressed as well, depending on how much of the wear is and what needs to go on. So that's what a full knee replacement is. It's not as though we chop out a segment of a leg and plug in a new knee. It's really a resurfacing of the end of the bone so that you get a nice smooth surface that will be pain-free and let you get back to life. So if you have any questions about any of these things, I'd be happy to address any of those. I know that this is very kind of fast and furious, and it's a lot to talk about. So any questions surrounding any of these things, I'd be happy to elaborate on that.
Great presentation, really good visuals too, as well, to go along with it. Excellent job. And we do have a couple of questions. I'm going to try to put them in order that makes sense. And the first question I have is just based off of what we just saw, and when it is time for surgery. Can you tell us, Doctor, how far we've come in terms of medical advancements? Maybe somebody may be remembering what it was like 10 years ago or 15 years ago for a joint replacement. What is the process like now? And what are we talking about in terms of downtime and physical therapy on the back end?
Sure. So what I tell people every day, in particular, if they're considering joint replacement, I I tell people, this isn't your mother's hip replacement. Oftentimes people have this sort of preconceived, uh, you know, my grandmother had her hip replaced and she was in the hospital for a month and she was on her back for 2 weeks. And it was just this long nightmare, prolonged, horrible experience. And so a lot of people are scared about surgery for those reasons. And so, really the biggest advances that we've made in joint replacement in probably the last 10 or 15 years have been around the management of patients. So it used to be that surgeons were just focused on surgery and we didn't think about the total picture and the management of people around surgery. And so, for example, pain medicine, we used to just give people pain pumps. Pain pumps are the worst pain management process that you could ever think of. What happens is you're in excruciating pain, they give you a button, boom, 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 you hit your button, you pass out. Why do you wake up? Because you're in excruciating pain. Boom, 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 hit your button, and you pass out. And it just creates this vicious cycle of medicines that create all sorts of other problems. They slow your digestive tract, they make you groggy, they create all kinds of problems aside from not managing your pain well. And so just the way that we've looked at pain management, we start managing pain now even before surgery. So it's common for now for my joint replacement patients, even before they even come to the operating room, they already have a multimodal pain management regimen that's on board. So we start addressing anti-inflammation, we start addressing nerve medicines, we start centrally blocking pain signals even before you have pain signals. So it's very common for us to put people through an entire joint replacement and recovery even after the operation, and they don't even need narcotic pain medicines. So they just occasionally use Tylenol afterwards to manage some discomfort. So, the pain management is a big, big difference. And then techniques. So the techniques that we use now generally would be considered very minimally invasive techniques compared to the way we used to do these things. And as we've gotten better with instrumentation, we've gotten better with specialized tables. For example, my specialty is what's referred to as the anterior hip replacement or the minimally invasive muscle sparing approach to the hip. And so I have patients that, we replace their hip through a 10-centimeter incision on the front of their hip. We put the hip in between the muscles. We have specialized equipment, specialized retractors, a specialized table that we use to do all of this without taking any muscles off of any bones. And so it's actually astonishing. We do these now even as outpatient surgeries because people are so comfortable and they're recovering so quickly, and they do wake up feeling better than when they came in. So the combination of the pain medicine, the multimodal pain approach, the minimally invasive techniques, and our anesthesiology team that help us address all of this, minimize nausea, utilize specialized blocks and specialized anesthetic techniques. When we look at the whole package and the whole picture together, people go through the process with very little discomfort, and they're really up and moving around and home oftentimes the same day. So it's a totally different animal from what it used to be, even 5, 10, or 15 years ago.
And then what does that look like? You said something that really got my attention when you mentioned surgery, and you said that the right patient or the motivated patient, and that made me immediately think of maybe the physical therapy on the back end. I could be wrong on that, but following surgery, what does that
Sure.
look like now?
Yeah, so that too is also very accelerated. And so what I mean by the right patient, some patients for whatever reasons aren't ready for the sort of what we refer to as the rapid recovery. Some people have such extreme deformities that it's just not safe. Or if your leg has been 35 degrees crooked in the wrong direction and we straighten you out, you might need a little bit more work with therapy in the hospital before you're ready to go home, just because you got to get used to walking with a normal leg now when you've lived with a badly deformed limb for a long, long time. So some people also have just not a safe situation to be at home right away, and so there's all sorts of factors that we need to think about, and that's what I'm sort of alluding to when I say the right patient or the patient with the appropriate motivation. I should probably qualify that with the appropriate support to to be home immediately after a big operation. But as far as a therapy routine, what I tell people is that the safest place for you and the best place for you to recover is if we can get you home, you sleep in your own bed. The closer you are to normal, the better you're going to feel. Eat your own food, all of those sorts of things. Staying in the hospital can be challenging because we wake you up every couple of hours. We're checking on you all the time. There's lots of noises, and some people need to be in the hospital. Some people have conditions that require hospitalization, and I'm not downplaying that, but oftentimes we can have people in and out and home really very quickly with the same multimodal pain management regimen at home. Anti-inflammatory medicines, nerve medicines, all of those same sort of things that they can manage on their own, and it works very effectively. And then we start you into outpatient therapy as quickly as you're ready to do that and safely to do that. So that's actually what we found to be the most effective and gets people where they want to be as quickly as possible is an aggressive outpatient therapy regimen. Usually we'll continue that for about a month or 6 weeks, depending on what people need. Some people less, some people more, some people don't even need therapy. With the minimally invasive muscle sparing anterior hip approach, there's really not a lot to rehab. What I tell people is I'd like to just see you walking around. And, I make therapy available to them if they feel like they need to fine tune something. And therapists offer a great service, and they can be really very helpful. But some people are, really motivated and really active, and just kind of guide that on their own. And I've had people go through the whole process and just be home right afterwards and not need any physical therapy, and they're doing wonderful.
Great. Yeah, the process, yeah, even I'm learning now, just sounds so much better than these things you hear about. These surgeries, and then that's something that's stuck in your mind because you may not need the surgery for years after the fact, and that remains in your mind as this is the way that it
Sure.
currently is.
Sure.
And it's wonderful to hear that we have advanced so far with technology to make it so much more efficient for your patients. Another question for you. Gout is a type of arthritis, right? Does high impact activity exercise make it worse?
So gout is this is sort of a term that has kind of like been left in the descriptors, like, or in the medical language, right? Gout is not by itself an arthritis. Gout, the process of gout inside the joint can lead to arthritis. Now they call these gouty attacks gouty arthritis, but it's basically the metabolic process that happens when you have this flare and the increased levels of the basically chemicals that precipitate into the joint that set the cascade in motion that lead to the swelling and the pain. That process is what can lead to the arthritis of the knee joint. Now, to answer the question, if you do have an arthritic condition, if you do have a compromised surface, I tend to caution people about really prolonged, high intensity, high impact activities because, if we know that your surface is not good, pounding on it is probably not the best thing for it. Now, can you do that safely for a period of time? Probably. I get asked this question very often. Is running bad for me? And I tell people, no, running's not bad for you. I've never replaced the knees of a marathon runner, but those marathon runners are probably very light. And so they, haven't been putting too much pressure on their knees, even though they've been putting them through millions and millions of cycles. So, it's not so simple. It's not just cut and dry. But if you do have you have a known cartilage problem, I would discourage somebody from just pounding on that problem, and in the hopes that it's going to get better, because that's probably not going to get better. But, incorporating all of these things into your lifestyle can definitely help.
Yeah, and you did a really good job in breaking down lifestyle choices, right? That certainly can either help us or hinder us when it comes to our joints. And weight is certainly a huge factor. So great answer there. Another question we have: when the muscle below the knee is painful, it feels like the support you need for the knee is in jeopardy. What do you do for that tissue along with knee replacement?
Well, it sounds to me that would be what sounds like the knee feels like it's going to give way. Oftentimes, people will describe that because as the surface is rough and it's painful when you're trying to use the knee, like going upstairs, for example, the knee will feel like it wants to give way because your brain, initiates your stretch reflex and wants you to take the pain away. So as you engage that joint and you pull that kneecap down into the joint when you're trying to go upstairs, and that rough surface hits the rough surface, and your brain says, "Oh my gosh, that's painful," then you may experience that giving way sensation. I find that's very common with patients who have these arthritic conditions, and that description that you provided about the muscle below the leg feels weak, it's probably something along those same lines. And so the most common likely explanation for something like that is probably some pain generating process inside the knee that is leading to that person feeling like they feel weak, or they shouldn't be, they're going to try to stop that stimulus. Your brain reflexively is going to make you stop doing that because it's painful. As far as bracing, really, when it comes to that, it's just really whatever makes you feel better. So I have people with terrible arthritis, and just wearing something simple like a little compression knee sleeve makes them feel better. So really, it's just trial and error. Something as simple as a $5, $3 compression sleeve, up to there's very elaborate braces that can try to help manage arthritis as well. So it's really just whatever helps make you feel better.
The next question: does scoliosis contribute to poor hip and knee joints, and what is the best way to help that?
That's a really difficult question because I do oftentimes see people who have really advanced scoliosis, and I even have a little scoliosis myself. And probably in my lifetime, I'll develop some deterioration between those levels, and that will alter some of your mechanics, and that may lead to a little bit of a different gait, and maybe a little bit extra pressure on your hip or your knee, depending on which side you might be leaning to. The challenge is that, well, what do you do about that? Are you gonna go have a huge back operation and have different levels of your spine cut, and rods and screws placed in there to try to get your spine to fuse a little bit more straight than it was? I'm not. I can tell you that. And so it's possible that may be contributing. Um, Unfortunately, this is the way the cards were dealt to us, meaning me and you, with our back conditions. So that's really a tough one.
Yeah, understood. And I thank you. I do myself have scoliosis, and others out there watching obviously do too. And that certainly can contribute to other factors that maybe those who don't have a twisted spine have to deal with later on in life.
Yeah.
One thing I want to go back to, in your presentation, you used the example of the woman who maybe spent a lot of time caring for others and maybe not so much herself. And when you finally get to see her and she comes to your office, as you said, you should have been here 10 years earlier. So for those of the viewers who are watching, if there's a checklist maybe that you have that people should look at, maybe the pros and the cons of what they have going on with them and their joints, when is it time to get intervention? When is it time to come see you?
Yeah. What I think would be probably the easiest thing for people just to think about is thinking about your day to day. And so oftentimes people will just start taking things out of their daily routine because of their hip or their knee or whatever it may be. For example, every night I go to, I have dinner, and I love to go for a walk after dinner. Well, now I notice that, I get to the front door and my knee is hurting me so badly. I just say, you know what? I'm not going for that walk tonight. Or you're waking up in the middle of the night with pain from your knee or your hip, or you can't roll over in bed because your hip is, just, you're having this excruciating pain. It's things like that I see people. They will tell me these things, and they'll experience them for years and years before they finally just get to the point where they say, God, I've just got to try to do something. And I know nobody wants to go see a surgeon, right? I mean, I tell people all the time, if you were excited about having an operation, I wouldn't do it for you, because that's not right. Nobody wants to have surgery, but you see people that just put up with these things for so long, and they get to the point where they're so debilitated, and they start to really compromise the quality of their life and take away all of the things that they used to love to do. Can't get down on the ground with my grandchildren, or I no longer do XYZ. Used to love to hike, can't hike anymore, or just all of that stuff. Just everything that you think about. They just start eliminating that, and they start modifying their activities. No longer buying shoes with laces because they can't bend their leg to tie their shoelaces, so they only buy slip-on shoes. Just little things like that, because your hip and your knee are so integral to every function of day-to-day life, and then they just figure out little workarounds to it, and then they've completely modified their life just to accommodate for their arthritic hip.
Yeah. And another question that popped up here, and we did talk a little bit about the physical therapy on the back end for surgery, but Kylie wants to know, how long do you have people in PT after surgery? And when you answer this question, doctor, can you maybe use a sliding scale from age ranges? We have people of all
Mhm.
different age ranges who are watching this, and if there may be a difference from somebody who's 40 to somebody who's 80.
Sure. And I would also tell you that the other differentiator there would be hips or knees. So some hips on the scale there would be literally from no therapy to maybe a month to 6 weeks of therapy. And you could probably break that down into, say, 20-year increments. So, 40, 60, 80, probably, a very reasonable broad stroke. When it comes to knees, partials or totals, a little less so on the partials, but generally they need a little bit more therapy. And in full disclosure, recovering from a knee is a little bit more uncomfortable and takes a little bit more work than recovering from a hip replacement. But usually, those patients, you could probably just add, say, 2 weeks to each one of those. So, young, really healthy, really motivated people with a badly arthritic condition, we do a partial knee replacement for them. They may only need, 4 weeks, 2 weeks of physical therapy, and then they kind of go off on their own and continue with their home routine. People that, maybe are 60, 70, 80 years old, 90 years old, and are recovering from a full knee replacement with, probably because they had a little bit more deformity, it was a little bit bigger operation. They might need, a month, 6 weeks, maybe 8 weeks of physical therapy.
And going back to what you had said kind of early on in the webinar about the low impact exercise and yoga. Do you find that people, especially maybe the older that they get, they say, "Oh, that's for young people. I'm too far gone for that." When is that the case? I mean, is that really true?
Well, really, what I would tell you is just find. Um, I guess the short answer is no. It's that's never the case, because you just need to modify these various poses, or I mean, if somebody's a diehard yoga enthusiast, there is plenty of things that you can do that are just going to be modifiable to what you can do. And if there are some 80-year-olds who have just tremendous capabilities, but there are also some that maybe are stricken with some arthritic conditions that are not going to permit some of these activities. But you can find a course, or you can find a routine that can be modified to what you can do. And everybody's just got to sort of find what their sweet spot is.
Right. And this is a question that literally just popped up, and it was going to be the next question that I was going to ask too off of these questions. So this works out well. Is there an anti-inflammatory medicine that I can take, whether it's an over-the-counter or prescription? I have no cartilage left in my knee and haven't for about 8 years. I am a 62-year-old female. And doctor, on the back end of that, we talked about vitamins, right? And how that may not help anybody, but what about glucosamine? And then what about the prescription medication like Boniva?
So to address the anti-inflammatory, um, if you need an anti-inflammatory medicine for a long period of time, you need to discuss that with your primary medical doctor, because those can definitely cause issues with your stomach, And the more we learn about some of those medicines, you need to also potentially be monitoring your heart and your response to those medicines. And you need to have that discussion with a true medical professional if you're going to need something like that for a long period of time. What I like to treat people with, which is very safe and has almost no downside, is Tylenol for arthritic pain. Tylenol is a very safe medicine. Tylenol gets a bad rap because if you take the whole bottle at one time, you can potentially, create serious damage, potentially life-threatening issues. But as long as you follow the instructions, and of course, if you're going to be on something for a long period of time, of course, your medical doctor needs to know about it. But Tylenol has almost no drug interactions, and for arthritic pain, it tends to be really very effective. Now, to address some of these supplements specifically, these things are, in my opinion, unfortunately not very effective. There's really no basic science and really no clinical evidence that they do a lot for you. I don't discourage people from taking them, because we do know that there is something to be said for what's known as the placebo effect. If I have high blood pressure and you give me a sugar pill and you tell me that it's going to lower my blood pressure in some people will lower. Now, why that is, we don't know why that is, but there is plenty of research that shows that kind of thing can happen. And so some people, they swear by these supplements. And if that's helping you get through the day and you're not suffering and you're not in agony because you're taking glucosamine, if you can afford it, I don't discourage people from doing that. But it is my job to tell people everything I know, and it's my job to interpret research and provide that information to my patients. And so when it comes to the real research on what do these supplements do, the real answer is they don't do a whole lot for you, but they still may be helping you in ways that we can't explain.
And then to the prescription, when we talk about healthy bones, do any sort of prescription medications, do they fall along the same lines? Is that what we're talking here, or are there
Yes.
some prescription medications that do help?
Yeah, I'm sorry. You had mentioned Beniva specifically, and I just it just slipped my mind. So when it comes to the management of osteoporosis and some of these medicines, these are also discussions that need to be held with the providers who are going to be discussing with you the pluses and minuses of these medicines. And the reason that I say that is this. So these are medicines that have side effects, and they also have positive effects. And so what you as a consumer of healthcare need to be made aware of, what are the potential benefits for you and what are the potential downsides? For example, when it comes to osteoporosis management, there are potential side effects to some of these osteoporosis medicines, like the bisphosphonate medicines that you're discussing. And your medical doctors will discuss that with you. You yourself need to decide, is it worth it to you to accept those risks for the potential benefits? So, for example, do you have a lower risk of breaking your hip if you were to fall and you've been on a course of bisphosphonate medicine? Chances are yes. And that can probably have a significant impact on your longevity of your life. Nobody wants to break their hip. And if we could avoid, people breaking their hips, that would be a huge, public health benefit, to everybody. So, there's no free lunch. Everything is a trade-off. You need to be aware of everything that you're taking and what you're trying to accomplish by taking it and what may happen as a result of taking it, just like anti-inflammatory medicines or just like any other supplement. It may help me if I take it. I may be losing money if I take it and it doesn't help me. It's just a trade-off. Everything has an up and a down.
Sure. And Kylie says, thank you for answering her question earlier. We have one more, and then we will wrap up our webinar. So the final question comes in here from Anonymous. Is there a preferred age when you would recommend a hip replacement?
So the short answer to that is no, because it's the same sort of answer as the medication question, because people are, in my opinion, people are the master of their own parts. And so you, as a consumer of healthcare or a hip replacement patient, you need to understand what you're going to get out of having your hip replaced, but what that means for you having your hip replaced for the rest of your life. For example, I've done these operations in teenagers because what do you do for a horribly arthritic rheumatologic patient who's crippled in their teenage years? They can't walk. So the discussion you have with that person is, okay, we can replace your hip or your knee or whatever it may be. You're only a teenager. There's no hip replacement that lasts 70 years, 80 years, whatever you're going to live. At some point in your lifetime, you're probably going to have more surgery. Is it worth it to you to accept that risk in the future and the complications that may result from these decisions for the chance to walk now in your teenage years? And generally those patients say, yes, I understand what that means. And we take care of these people for years and years and years, and but it's the only option that they have. And so for this person, I assume this is a young person who has an arthritic hip. And if I were to meet that person and talk with that person, I would say, okay, here you are, you're 40 years old. You're probably going to live to be 100. So what does that mean? If we do a hip replacement for you when you're 40, chances are you're going to get 25, 30 years out of it. Then we're looking at another operation. That's if we avoid any complication around surgery. Complications are very small, but they're not zero. And so this is the calculation that people who are considering something like this need to take into consideration. Is it worth it to you to have an implant that is pain relieving, works well for you, with the trade-off that someday you may need another operation? If somebody's 85 years old, terribly arthritic hip, can't live that way, bad knee, chances are we're going to do one operation for you. You're going to be good for the rest of your life, and you're probably not going to need to worry about it. So it's this is why we're not replaced by computers, because there's no absolute algorithm for every single individual circumstance, and there's no substitute for putting all of those things together for individuals. So it's tailored based on individual people.
You do such an excellent job, Dr. Hohman, of really breaking down this information in a simplified way that we can all understand. So as we wrap up here, first, we appreciate your knowledge and sharing that with us and our viewers today. Now, if someone has more questions for you, or if they want to get in contact with you or your practice, what is the best way that they can reach you?
They can just call me here at our office if you need. I actually don't have our email addresses on there, but we also respond to those. So if it would be my first name dot last name at HCA Healthcare.
Okay.
We field those kind of questions all the time. Any of my medical assistant or my physician assistant, we return calls all the time. So if anybody has any questions, or if there's anything we can do to help anybody, that's what we do. We do this all day, every day. So we're readily available. And I would also, if anybody has any specific questions, if you have interest and you're considering a joint replacement and you're somewhere else, even on our Facebook page, I'm the only Dr. Hohman on Facebook, or our Instagram, or any of our other outlets. We have lots of videos and people talking about their experience and educational resources surrounding all sorts of stuff like this. And I think it'll answer a lot of questions that maybe we didn't have time to go over this, because these are huge topics. So maybe we could do this again sometime and talk about specifics around one thing. And as you can tell, I tend to ramble and I like to talk a lot, so I can fill your time for you.
It was all great information, I guarantee that. And so that is another resource for those of you watching. You can head over to Dr. Hohman's website, where you can see, as you mentioned, some videos that can help break this down just a little bit more, give you a little bit more information and some facts to back that up. So thank you so much, Dr. Hohman, for taking the time to be with us today.
Yeah, it's my pleasure. Thanks for having me. I hope that's helpful.
Absolutely. And we thank you, of course, the viewer, for watching. This video, just so that you know, will be available to watch starting tomorrow. You can share it with your friends, your family. You can go to www.seniorlivinglive.com, and there you can access our full vault of senior living videos and tips 24 hours a day, 7 days a week. We hope to see you again soon. Have a great day, everybody.